My name is Anthony Trevor. I'm a professor of pharmacology at the University of California in San Francisco. I did my graduate work in London University, but I've been at the University of California since 1965. Most of that time I've taught medical students in the formal medical pharmacology courses. I've also done a considerable amount of review teaching for Step 1 of the USMLE. We're going to start pharmacology by first looking at the basic principles. Basic principles as a section actually probably would account for perhaps 7 or 10% of the questions on a Step 1 examination. One usually spends a reasonable proportion of time on this because it relates in large part to much of the pharmacology that we'll describe under drug groups a little later. We're going to start with a couple of definitions. First definitions are the meaning of the words pharmacokinetic and pharmacodynamic. Pharmacokinetics refers to the characteristics of drugs that concern their absorption, their distribution through the body, their metabolism, and their excretion. And these properties are called pharmacokinetic properties. Pharmacodynamics concerns the actions of pharmacological agents. This concerns, for example, the therapeutic uses of a drug group, the mechanism of action of a drug group, the toxicity of a drug group, and obviously the side effects of a drug group. And dynamics really is what the drug does to us, whereas kinetics is what we do to the drug in terms of its biodisposition. The word biodisposition means how the biology of us disposes of drugs. So pharmacokinetic characteristics concern what happens to the drug in our body, and pharmacodynamic characteristics concerns what the drug does to our body. Now, under pharmacokinetics, which, as I say, includes absorption, distribution, metabolism, and excretion, we have to first focus on the matter of how it is that a drug molecule can get to where we want it to work. This ability of a drug to move across biological membranes is referred to as permeation. A drug's got to be capable of permeating through the lipid bilayer of cellular membranes to exert its actions. And in order to do that, it has to have some properties that would favor such permeation. One of those properties happens to be its ability to dissolve in the lipid matrix of a biological membrane. In other words, lipid solubility is a feature of drug permeation. If a drug is totally water soluble, it probably will not cross a biological membrane very well. It must have some degree of lipid solubility, otherwise it will not get where you want it to get to in terms of having an action on our cellular functions. So lipid solubility is probably one of the most important determinants of drug permeation across biological membranes. Secondly, since most drugs cross membranes by passive diffusion, you may remember from physiology, really is a concentration-dependent phenomena. The rate with which a drug can passively diffuse across a membrane depends on the concentration differences between both sides of the membrane. Therefore, if you have a great amount of drug on one side of a membrane, this will act as a driving force to push the drug across that membrane and presumably into the cell. There are two other determinants that are less important really for our purposes, but you should know about them. Certainly the surface area of a site of absorption can be very important in the ability of a drug to get in, for example, from the GI tract into the systemic circulation. An example, the stomach has a lining that is smooth. Drugs can cross the stomach membrane to get into the blood, but far greater absorption will take place in the small intestine, where we have the villi, and all the convolutions of the villi allow for a much greater surface area. So as a general rule, when you take a drug orally, more of it will be absorbed from the small intestine than it would from the stomach itself. And that relates then obviously to surface area. The other property that's of some relevance is vascularity. If I were to inject a drug into one's muscles, which are heavily vascularized, we can anticipate that the drug would get into the bloodstream fairly quickly. And that is true, and we use intramuscular administration to be able to do that. On the other hand, if I was to inject a drug into adipose tissue, perhaps, in the haunch, as it were, then you will find that there's very little blood supply to that tissue, and it would take much longer for the drug to get into the systemic circulation. So actually, vascularity also plays a part. So reminding ourselves again, the most important single property is lipid solubility in terms of permeation. But these other properties, such as concentration gradient, surface area, and vascularity, are also important to remember. Now, it may surprise you to know that about 80% of the drugs we use in medicine, chemically speaking, contain groups that are capable of ionization. And those groups are referred to as either acidic chemical groupings or basic chemical groupings. So we often use the term a drug is a weak acid or a drug is a weak base. For example, aspirin is known to everybody. Its real name is acetyl salicylic acid, and that is an acidic compound. Morphine is known to everybody. Morphine is a basic compound. And when drugs have such acidic or basic groups, they can exist in the two forms, one where they have a charge on, which is called ionized, and one where they are uncharged or non-charged, and that would be called non-ionized. And the equilibrium between ionized and non-ionized forms of a chemical grouping depends on two factors. The first is the pH at which the drug is dissolved in terms of the media. What pHs have we got in our body where we could imagine there would be differences in terms of a drug's ability to be ionized or non-ionized? Well, if we go back into the GI tract, the stomach pH is in the range of 1.5 to 2. That's a quite acid environment. As we go into the small intestine, of course, the pH becomes closer towards neutrality. In the blood, we expect it to be pH 7.4. What can we imagine would occur in the kidney in terms of urine pH? Well, possibly as high as 8 if you alkalinize the urine, possibly as low as maybe 5 if you acidify the urine. These are the pH ranges that are relevant to us regarding ionization of drugs. So those are the things we keep in mind, and in particular we're very interested in urinary pH because this is one of the most important features regarding drug ionization. Now, the second property that determines what the ionization state is called the pKa. Now, pKa is a physicochemical characteristic that is defined as that pH at which an ionizable group is 50% in the ionized state and 50% in the non-ionized state. In other words, if pH equals pK, then we have a 50-50 relationship of ionization as opposed to non-ionized forms. Now, the importance of this is very critical for you to know. Only non-ionized forms of drugs are capable of crossing biological membranes. So this means then if a drug molecule has a charge on it, it is probably not going to be lipid soluble. It probably is going to be more water soluble and therefore find it more difficult to cross a biological membrane. If there are no charges on the molecule, if it is non-ionized, in other words, then this would make it more favorable for drug permeation. Now, what are the good examples for you? Probably as an acidic grouping, I don't think we need to go beyond the idea of a carboxyl grouping. As you can see on this slide, we have a weak acid and a weak base represented. And I've left out the chemistry of the drug. I've called the drug R in both instances, but you can see the chemistry of the acidic and basic groupings here. So a COOH is a carboxyl grouping, present on many drugs, of course on many amino acids for that matter, and it can exist as such, R.COOH, or it can lose a proton, a hydrogen ion, H+, and therefore could exist, since we're taking away a positive charge, as a negatively charged carboxyl ion, COO-. This means then that there is an equilibrium between the non-ionized, COOH, and the ionized form of a weak acid, like, for example, aspirin, acetyl-salicylic acid. Now, which form crosses membranes? The non-ionized form. In other words, the form that has no charge on it, no negative charge on it, COOH. And that is capable of crossing a membrane, and that's the form in which aspirin will get to where you want it to get to when you administer it. Now, on the other side, we've got a weak base. A weak base, one example of a weakly basic grouping would be the amino function, an amino group, NH2. And you can see that NH2 has no charge on it. So on the right-hand side of the figure, we see a basic compound, R.NH2, where there is no charge on the molecule, and that is the form, the non-ionized form, that can readily cross biological membranes. However, if one was to add a hydrogen ion is a proton, to the NH2 grouping, we would have a basic grouping R.NH3+, because we've gained a positive charge. Now, obviously, that's an ionized form of a basic grouping. That does not cross membranes. The grouping that crosses membranes is the RNH2, and that has no ionization, no charge on it. It's not an ionized group. It has no charge on it. Now, you'll notice that at the top of the figure, we've got what happens in acidic media compared to what happens in basic media. If you're a weak acid, if a drug is like aspirin, in acidic media, where the pH is less than the pKa, we have a preponderance of the non-ionized form of the drug. So, for example, if I were to take an aspirin tablet and it dissolved in my stomach, where the acid is, the pH of the acid in the stomach is about 1 or 2, then we can absorb aspirin across our stomach, because most of the aspirin in our stomach is in the form R.COOH. In other words, is not ionized. Now, it would be quite the opposite if we were to then refer to a basic compound, like, for example, morphine. Morphine in the stomach is not readily absorbed because most of morphine in the stomach is in the ionized form, R.NH3+. So it requires less acidity for morphine to be absorbed well from the GI tract. On the right-hand side, you see what happens in the basic media. In basic media, where the pH is greater than the pKa, then we have the opportunity to form the non-ionized species as far as, say, a drug like morphine is concerned, and that then can cross membranes. So this diagram or figure it represents for us then a comparison between acids and bases, and you can see they work in opposite directions. Changes in pH have opposite effects on acids and bases. You can see that also in the representation of quantitation of ionization. Many years ago, Henderson and Hasselbalch derived an equation that related the degree of ionization of a molecule to the pH and the pKa. There are various forms of this equation. In physiology, we use a very different form from what you see here. But for pharmacology, we find it convenient to actually rearrange the equation in the form that you see. And we have pH minus pKa for both weak acids and weak bases equaling a log function of the relative ionization in terms of concentration ionized over concentration non-ionized in the case of a weak acid, and the reverse of that in the case of a weak base. So if instead of being concentration ionized over concentration non-ionized, weak base is concentration non-ionized over concentration ionized. And you see that in these two relationships here. Now, the reason for our presenting this in this form is to get you ready for what might be a possible question about Henderson-Hasselbalch. If one sees, in a question, a pKa and a pH, it's sort of inviting you to take one away from the other. And in actual fact, that's what you will do. You will take the pKa away from the pH and come up with a number. And if you come up with a number, that will tell you the relative ratio of ionized to non-ionized forms of a drug. You're not asked to do any log functions. You can't do those in terms of an examination, but you should at least know the direction of the ionized and non-ionized relationships. I'm going to show this to you on the next slide, which happens to be a figure representing what happens to bases and acids when you look at differences between pH and pKa. Let's start in the middle, where we have no difference between pH and pKa, which gives us then pH minus pKa is 0. Now, this by definition, the pKa is that pH at which 50% of a drug is ionized and the other 50% is non-ionized. So you can see that both weak acids and weak bases here reach that midpoint, the 50% mark. But then when you go in either direction away from pK equals pH, then acids and bases move in the opposite direction. Now, on the left-hand side, we have an arrow going upwards that shows us the percentage of a form that would be non-ionized if, for example, pH minus pKa was -2. In other words, the pK is higher than the pH. And you'll notice that in the case of the acid, most of the molecules are going to be turning out to be in a non-ionized form. And that's at the top of the left-hand side. And in the case of a base, quite the reverse. Actually, at a pH minus pKa of -2, I can tell you that 99% of the molecules of an acid are going to be non-ionized, which means that only 1% are ionized. And then the opposite is true for a weak base. When pH minus pKa is -2, only 1% of the molecules are in the non-ionized form, 99% of them are in the ionized form. This does have an impact, as you'll see just a little later, on the clearance of a drug, particularly clearance by the kidney. And you'll notice that on the right-hand side of the diagram, you can see that what happens in terms of the differences between pH and pKa on the clearance. You'll be able to backtrack to this figure later, but first I want to describe something else to you. Here's a table that shows the data that you just saw as a figure. And this is probably worth your memorizing. It's not too difficult to memorize. It looks complicated, but it really isn't that difficult. Because if you were to start, for example, in the middle and say, okay, I know what pH minus pKa is at 0. When that's 0, everything's 50-50. Wouldn't matter whether it's a weakly acidic compound or a weakly basic compound. It's always going to be 50-50. What if we then just move to the left just a little bit and say, well, what happens when pH minus pKa is -1? When we do that, we find that as far as a weak acid is concerned, that becomes 90% in the non-ionized form. If we move to -2, you'll see it becomes 99. Now, really, from the standpoint of memorization, that is about as far as you need to go, because if you knew that, then what you could say to yourself was that actually a weak base must be the opposite to that weak acid. So, for example, if I went to -1 for the acid, which gives me 90% non-ionized, then I probably have got the opposite number, the 10%, for a weak base. And you'd be quite right. And if you went to -2, 99, what's the complementary number? 1 for a weak base. Now, if you're capable of doing that in terms of moving on the negative side, you can also do it fairly easily on the positive side. So when pH minus pKa becomes +1, you know that that's got to be, for a weak acid, 10% non-ionized. If it's +2, it has to become 99% non-ionized in the case of a base. All right? And so you can actually look at this table, and all you need to really remind yourself is the first part of it. I'm going to give you an illustration. Here's a typical type of question that could be addressed to you. Morphine is a weakly basic compound. Its pKa is about 8. It's not exactly 8, but we'll use 8 for our purposes here. So if morphine was in the urine at a pH of 6, what percent would be ionized? Well, from the table, we said pH minus pKa for a weak base at -2 is 1% of a form that's non-ionized. So this means if 1% is non-ionized, the percentage that would be ionized is the complementary number, 99%. So 99 out of 100 molecules of morphine in the urine at pH 6 are in the ionized form. And what did we say about ionization? We said ionized forms of drugs don't cross membranes. So that would mean then, if morphine is in the urine at pH 6, only one molecule out of 100 would easily get back into the bloodstream by crossing the tubular membrane. Most of the molecules actually would be in a state that would favor their elimination from the body, the clearance, if you like. So this is the importance, really, of the Henderson-Hasselbalch for examination purposes. It's really to make predictions about the movement of drugs across biological membranes when you know their pKa and you know their pH. Here's a summary of why ionization is relevant to renal clearance. It goes this way. First of all, recognize that if a drug is in the blood and the blood supply is directed to the glomerular apparatus in the kidney, here is a mechanism for filtration. Filtration only allows for drugs that are free to cross into the tubular lumen, the lumen of the tubules in the kidney. And bound drug, if it's bound to a plasma protein, cannot cross through the glomerular apparatus. So you filter free drug into the, if you like, the lumen of the tubule of the kidney every time blood gets into the glomerular apparatus. Now, it doesn't matter whether the drug is ionized or non-ionized regarding filtration, because ions can be filtered and non-ionized forms of drugs can be filtered. However, only non-ionized forms of drugs can be actually reabsorbed across the tubular membrane, and only non-ionized drugs can actually undergo secretion across that membrane. If a drug is in an ionized form, essentially it's stuck in the lumen of the tubule and ultimately then will pass down and be present in the urine and can be eliminated from the body by that mechanism. So in a sense, filtration traps ions in the urine. And we use that term sometimes, the trapping of an ionized form of a drug, and that would then be in a form that is not readily reabsorbed across a biological membrane. So this is why we actually go through the Henderson-Hasselbalch, largely because of the possibility of manipulating urinary pH to actually enhance the elimination or restrict the elimination of a drug from the body by changes in pH. Here's a summary of what happens in terms of how ionization can influence renal clearance of drugs. If you acidify the urine, you increase the ionization of a weak base, and this will increase its renal elimination. Do we do this? Yes, we do. In cases of overdosage with weakly basic compounds, like, for example, amphetamine, phencyclidine, other drugs that sometimes are responsible for toxic syndromes, we try to encourage their elimination through the kidney by acidifying the urine. And you'll do that with ammonium chloride. Now, what about alkalinization of the urine? We can do that by taking sodium bicarbonate, for example, and this is a mechanism for encouraging the elimination of drugs that are weakly acidic. So, for example, in an overdosage of aspirin, aspirin being a weak acid, we will encourage its elimination from the body by forcing the drug into a form that is ionized by simply making the urine pH alkaline. And the ionized form of acetylsalicylic acid is not reabsorbed across the renal tubule, so this is a mechanism of encouraging its elimination. So if you could remember an example of a weak acid, and what you do for weak acids, what you do to try and get rid of a weak acid is actually increase the pH, right? Acid, A for above. And what you do for bases is you try to lower the pH of the urine, B for bases, B for below. That might help you remember which direction you should be pushing urine pH. Now, we spend a good deal of time on ionization because it is very critical regarding the movement of drugs across biological membranes, and you can see that in the context of elimination. There are really three ways, actually, that drugs can get across membranes. They do largely by passive diffusion. That's probably the most important way that drugs do cross membranes. And as we've said, you need a degree of lipid solubility to do that. You don't require energy, but you do require a concentration gradient. All right? You've got to have a direction, if you like, a down gradient direction. And you can't readily saturate that type of mechanism. Doesn't matter how many molecules you have one side of a membrane, you're not really ever going to saturate that mechanism. There is another form of diffusion which is not passive, but which is actually related to carriers, and that's called facilitated diffusion. That happens, for example, with some amino acid drug derivatives. It's not common. Again, it is down the gradient, but this does require a carrier mechanism, although it doesn't require energy. And whenever you have a carrier mechanism, you would guess that you probably have only a finite number of carrier molecules, and that means that you're going to be saturable. It's almost certain. The third mechanism by which drugs will get across a membrane is active transport. This certainly not only requires a carrier, but it requires energy, usually in the form of ATP. This is certainly a saturable mechanism, but it can work somewhat differently from the other mechanisms in the sense it can go upstream. It can go against the gradient. Usually we're talking here about a concentration gradient, but it can also work in some systems against a voltage or electrical gradient as well. Examples in pharmacology of this latter type of mechanism get us back to the kidney again. Many drugs actually undergo active tubular secretion. We've just been talking about aspirin. Aspirin actually can be secreted and reabsorbed across tubular membranes. But the very famous drug groups that can be actually substrates for mechanisms of active tubular secretion are the penicillins. The penicillins have very high concentrations in our urine. Why? Well, because we secrete them across the tubular membrane, the luminal membrane of the tubules, to give us very high concentrations in the urine. That's why penicillins, in many instances, are perfectly good as drugs to clear away a urinary tract infection, because the concentrations are very high in the urine, and it sometimes is of value. We can inhibit that tubular secretion by certain drugs. You may remember the drug probenecid, which is used in gout, for example. It's a uric acid drug. Probenecid also inhibits the tubular secretion of many weakly acidic molecules, like the penicillins and the cephalosporins, etc. Other drugs which we really need to identify that are substrates for active tubular secretory mechanisms are the diuretics of the thiazide and the loop family. Both of those classes of drugs are good examples of drugs that can undergo active transport and be secreted into the urine, giving you high concentrations there. So I've given you some very special examples of active transport, but for the large part, most drugs cross membranes by passive diffusion. So don't ignore that that's still quantitatively a very important mechanism. Now, so far we've been talking in general principles about how drugs cross membranes. Now what I want to do is to talk about the different aspects of pharmacokinetics, starting with the idea of absorption. Absorption can really be defined as the processes involved in the entry of a drug into the systemic circulation from its site of administration. The determinants are simply those of permeation. And what were they again? Lipid solubility, certainly, a concentration gradient, the vascularity, the surface area, These four things that we talked about for drug permeation are all relevant to absorption of a drug into the systemic circulation. There is only one mode of administration where the drug does not undergo absorption processes, and that is if you inject it directly into a blood vessel. So intravenous administration, for example, or intra-articular for that matter, but intravenous is much more common, IV drug administration does not require absorption because you're putting the drug directly into the blood. So there's no absorption involved there. We talk about extravascular administration whenever we don't use intravenous administration. So for example, per oral or PO, or oral administration if you want to simplify it, is an extravascular means of drug administration and therefore has to undergo absorptive processes. We mentioned that a little earlier when we said that we could absorb some of our aspirin from the stomach itself because the pH is favorable. It pushes aspirin at low acid, low pH in acid contents of the stomach towards the non-ionized form, which is capable of being absorbed. But the bulk of aspirin happens to get absorbed in the small intestine because of the high surface area there. This is an extravascular means of administration and therefore goes through absorption processes. Other modes of administration that we'll need to refer to from time to remind you about include intramuscular, IM, subcutaneous, SC, and inhalational modes of administration. That latter, of course, comes in very importantly in the management of asthmatic patients and, of course, in the use of inhalational anesthetics. So we'll need to say something about those modes and absorption of certain drug groups by these modes of administration. In some cases, extravascular administration may actually be incapable of providing you with the complete amount of the drug into the systemic circulation. We refer to variations in, quote, bioavailability. Bioavailability means how much of a dose actually gets into the blood. And although in some cases a drug administered IM or orally can actually all get into the blood, in which case we call it 100% bioavailable, in other instances there may not be complete absorption and therefore there may be some variations in bioavailability. I will show you in a short time how you actually estimate the degree of bioavailability. Now, the figure that you see in the next slide I'm going to describe for you, and then some of the characteristics are also represented in the following slide. This is meant to imply a mode of administration of the drug that is not directly into a blood vessel. In other words, is extravascular administration. And you can see that there is a period of time, if you follow from the junction of the two axes, if you follow along the horizontal axis, you can see there is a period of time after administering the drug where you can't detect the drug in the blood. And that is referred to as the lag time, where there is no difference in between, knowing the drug is there or not knowing the drug's there. You can't detect anything in the drug in terms of plasma concentration for a period, which could be quite short. I think that makes sense. I mean, obviously, if I just took an aspirin tablet now and then you took my blood immediately, you won't find anything in the blood immediately. It takes time before you can get into the systemic circulation. It's referred to as the lag time. But then if you follow what happens to the blood level, you'll notice that it begins to go up, and it eventually reaches a point where we're beginning to see some pharmacological effects. And that is shown by what is called the line that's going across horizontally, representing minimal effective concentration. And the minimal effective concentration is when you first get to see pharmacological effects. Perhaps it's an effect that is simply, relieving a headache or whatever it may be. But in any event, that is requiring a certain blood level before you see that pharmacological effect. And that, if you like, minimal effective concentration in the blood is, where the drug is beginning to work. Now, in many instances, of course, blood level continues to rise. And in some cases, of course, that increases the intensity of pharmacological effects. Not always, but sometimes it does. And eventually, you'll peak out. And the blood level will reach the peak here, and the time to peak is one of the characteristics that we talk about regarding the kinetics of a drug. How long does it take before you reach a peak plasma level? So from 0 time to the peak level is the time to peak level. There's nothing very fancy about that, and all we need to say about it is the Tmax, the time to peak level. From that point on, unless you take some more drug, now you're beginning to see a decrease in the blood level of the drug, and ultimately you'll come back down to what was the minimal effective level. And we'll pass beyond that and get to levels which are not doing anything for us, which represent mechanisms of elimination of the drug from our body. Remember this, that if you take a drug that didn't ever go out of the body, you'd never need to take it again, would you? Right? So obviously elimination is the reason why we have to take more doses of a drug, because we're losing the drug. In any event, the difference between the two time points where we reached the effective concentration and then when we went down below the effective concentration represents the duration of action of the drug. So you can see now why we use the term pharmacokinetics. Everything relates to time. Kinetics is movement or time, and everything here in this figure relates to time. Now, there's nothing very fancy about it, but I thought you might like to see it also in a tabular form. So Cmax is the maximal drug level obtained. Tmax is the time taken to achieve the Cmax. The lag time, as we said, is the time to the first appearance of the drug in the blood plasma. The onset is the time it takes to reach the minimal effective concentration. The duration is the time that it's above the minimal effective concentration, and the time to peak represents the time to the maximum plasma level of the drug. So this is just then the, if you like, the verbal representation of what you saw in the prior figure. Now, I told you that I wanted you to know how to look at bioavailability. Bioavailability is generally determined by comparing the same dose of a drug given intravenously with the dose of a drug given by the mode of administration that you will be using clinically. And you can see that what we have here are two rather different types of curve. We have a curve where it's sort of appearing from at the top edge of the figure and then dropping down and getting slower and slower. That's called an exponential curve. And then you also see another curve, which is very like the one you just saw in the prior diagram, which would be a curve of increasing blood level following administration by a means that is extravascular. The curve that shows the exponential would be typical of an IV bolus dose of a drug. In other words, you put it into the blood, it's immediately mixing in the blood. In one circulation time, you've got your maximum blood level there. From that point on, it's declining. So it runs through an exponential decay. Now, what you do then, in terms of determining, say, the bioavailability, and in this instance, as you see in our diagram, we're saying we're comparing oral with intravenous administration, is you get a subject and you give them an intravenous dose of a drug. And you measure the plasma levels as they decline on this exponential. And you then plot this on a piece of graph paper so that you can see the plasma levels as a function of time. And what you can do then is measure the area under that exponential curve. It sounds like fancy, and I'm sure that when you're a pharmacokineticist, you do it by mathematical things, but you could actually do it yourself by just actually plotting this on squared graph paper, because all you've got to do is to count up the squares between the vertical line, the horizontal line, and the exponential line. And if you counted all the squares in there, you'd get an estimate of the area under the curve. Now you give the patient or the subject a dose of the drug, the same dose, but this time orally. And as you can see, it takes a little bit of time before you can detect it in the blood, and there will be a peak level appearing somewhere in terms of time, and then it will decline. And you do the same thing here. you actually measure the area under the curve for the oral administration of the drug. And once again, I'm sure there are mathematics that will allow you to do it, but you could just measure the number of squares under that curve. You get a rough approximation of the area under the curve. Then you compare the two, and you compare what is the oral curve with the IV curve. Area under the curve PO over area under the curve IV gives us the bioavailability as a fraction of the dose given by intravenous administration. And so we use the term F for fraction, and that refers to the bioavailability of the drug by that particular mode of administration. If you were to scan your eyes back on this diagram and you were making a sort of a guesstimate of what the areas were under each of these curves, you'd probably say they look rather similar, don't they? I mean, after all, you know, you could say, well, okay, that's in common, and then I could take that bit that is from the PO and stick it on over the bit that's from the IV drug, and it probably comes to something very, very equivalent. This type of curve would suggest that the oral administration of a drug is just as good as giving it intravenously in terms of how much gets into the blood. And that indeed is the fact. But that is not always the case with drugs. In many cases, we have drugs where the area under the curve oral is quite different from the area under the curve intravenous. You want an example? Propranolol. Everybody knows propranolol, the most famous beta blocker out there. But maybe you don't know that only a quarter of every oral dose of propranolol gets into the blood. 3/4 of it disappears. Its oral bioavailability is 0.25. In other words, 1/4 of the drug gets in by the oral route. Where's the other 75%? I don't know, but it isn't in the blood. All right, so presumably it's gone on to other parts of our body. All right, but it doesn't get into the blood. So remember this, intravenous doses have 100% bioavailability. F equals 1. And that's not the case for all drugs. There is one area of bioavailability that gets asked about more than any other, and it concerns per oral administration, oral use of drugs. And the fact that when you take a drug orally, it is actually absorbed into the portal circulation. And the portal circulation takes the drug directly to the liver. Do not pass go, do not collect $100. In other words, it goes straight to the liver. Now, if the drug happens to be a good substrate for liver enzymes, it might be metabolized in the liver. And in fact, that's what happens to propranolol. Some of propranolol is metabolized in the liver, therefore never reaches the systemic circulation. This is referred to as the first pass effect, or sometimes you'll see it referred to as first pass metabolism. In other words, the first time the drug sees the liver, it is extensively metabolized, and this obviously decreases its bioavailability by the oral route. That's a very important one to know about, and that's why I emphasize it for you. Now, this all concerned absorption. Now, what's the next step? You've got the drug into the bloodstream. Where's it going to go from here? Well, that's called, the processes of where it goes from here is called distribution. So the drug is going to be distributed to different parts of our body. In most cases, drugs really can't control where they go. We have a very few sorts of drugs that can be directed towards a particular organ or a tissue. So most of the time drugs go wherever the blood will take them, and they will get into tissues, again, as a function of their lipid solubility or their state of ionization, etc. So once again, the same parameters that we talked about earlier are at play here in distribution of drugs. You know, if a drug is lipid soluble, it will get into your tissues, all right? And if it gets into your tissues, maybe it even likes our fat tissues. You know, if it's very lipid soluble, it'll accumulate in our fat tissues, actually. So, you know, those determinants are still the same here. But there is something else that's a little bit odd here regarding another determinant of whether a drug gets anywhere, and that is the binding of drugs to proteins in our plasma. We hinted at this a little earlier when we said that drugs bound to plasma proteins do not get filtered through the glomerular apparatus. That is true. You see, they're stuck on a protein. And a protein is not filtered. Proteins, I mean, if proteins were filtered, we'd be constantly having to make proteins in our blood. Unfortunately, they are not filtered, and they stay behind in terms of the glomerular functions. But if a drug is bound to a protein, of course it hangs in with the protein and does not get then filtered through the glomerular apparatus. Neither does it get anywhere else, for that matter. In other words, bound drugs tend not to cross membranes. They can't. They're stuck on a protein. Bound drugs tend not, if they don't cross membranes, to cause pharmacological actions. It's the free molecule that's capable of doing that. And as you can see on the slide here, there is a sort of an equilibrium in the blood of drug molecules that are free and drug molecules that are bound to protein in a complex. And it's only the free drug that can really do anything. It's the free fraction that's responsible for pharmacological effects. Right? What proteins are we talking about here? Well, the dominant protein in the blood which drugs bind to is albumin. But there are many other proteins as well, glycoproteins of various sorts. You can have drugs bound to them and form the same sort of equilibrium between free and bound drug. That particular fraction of the drug that is free is called the free fraction. So if I said to you, the free fraction is 0.5, that should imply to you that there is 50% binding, because half of it must be free, the other half must be bound. You get the idea? It's not a big deal, but in essence, what we're really saying is that the free fraction is a percentage of the drug that is free. Now, this is interesting in and of itself, but it's particularly interesting when it comes to drugs that compete with each other for plasma protein binding. Because it's here, you see, that you can get yourself into changes in the free fraction. And since the free fraction is the amount of the drug that determines concentration gradient across a membrane, because you see the bound drug can't do that, it's nothing to do with the concentration gradient, then changing free fraction can change the intensity of a pharmacological action if, for example, drug X displaces drug Y. And drug Y obviously is extensively bound, but now you're making some of it more free. And that can change pharmacology quite drastically. I always use as my illustration here the drug warfarin, not only because it's one of the top 10 drugs asked about on exams, but also because it's such a widely used drug. We estimate somewhere between 5 and 8 million people at any given time in the United States are on warfarin. And warfarin is a blood thinner, is an anticoagulant. Well, what you need to remember in the context of plasma protein binding here is that warfarin normally is about 98% plasma protein bound. And that means that only 2% of the drug in the blood is capable of doing anything. And what do you want it to do? What you want it to do is to cross the liver membrane and inhibit the synthesis of coagulation factors, including prothrombin. And if it doesn't get into the liver, it can't do that. Well, what determines how much gets into the liver? The concentration gradient. Well, what's the concentration gradient under normal circumstances? Well, you set it up so that you do a prothrombin time and you get the dose right that will give you the right effect on the coagulation factors. And that's responsible, that comes from 2%, free drug. Now, along comes another drug. And the other drug comes along, and it displaces not too much warfarin. It doesn't have to displace too much. Supposing it only displaced another 2% of that which is bound. What's going to happen now to the free fraction? Instead of the free fraction being just 2%, it becomes 4%. That doubles the gradient for the drug to get into the liver. And that has a marked effect on inhibition of coagulation. And in fact, can commonly lead to bleeding episodes. So this is a drug interaction that has a great deal of clinical significance, and that's for the reason I mentioned warfarin to you in this regard. Among the drugs that can compete with warfarin for the binding to plasma albumin are the fairly commonly used drugs that are antibacterial sulfonamides. and sulfonamides can displace warfarin from plasma albumin, thus enhancing its anticoagulant effects. So this is really the reason why I needed you to know about plasma protein binding. Very unlikely that you would ever be asked to do calculations on plasma protein binding, but certainly you should know the qualitative features of the phenomenon. Now, there are a couple of special barriers to drug distribution. The placental barrier is one of these. We protect our developing fetus by virtue of having barriers to certain molecules, but they're very weak, I must say. Most drug molecules tend to be capable of getting into the fetal circulation, although the blood level in the fetus, in the fetal blood, for example, is going to be lower than that in the mother's blood. But we're still concerned about that. Why are we concerned about it? Well, certainly during fetal development, we're concerned about drugs known to influence development. In other words, that drugs that might have embryotoxic effects, or drugs that might be referred to as teratogenic. A teratogen is a drug that has an effect on the development of the fetus that causes usually structural abnormalities. But they don't have to be structural. There can be other abnormalities as well. And we're concerned about that. And it's always important for us, as we go through a review of pharmacology for our exam, that we know which drugs to be avoiding in pregnancy because of the ability to have embryotoxic effects. There is also another area of interest regarding placental transfer of drugs that comes into play just around the time of delivery. Now, what are we talking about here? We're talking about drugs that might be given to the mother at around the time of delivery, perhaps to ease pain of the delivery, for example. These drugs can also get into the fetal circulation. And remember that the fetal circulation becomes the neonatal circulation when the fetus becomes the neonate, right? And that means then the neonate may have some drugs on board that they got from mum when mum was having the drugs to handle, for example, whatever conditions were at play during the delivery. And that also is relevant to us, because in many cases, mum needs a downer. What do I mean by a downer? Something that depresses central nervous system function, right? For pain relief or sedation or what have you, and sometimes even anesthetics. All of these molecules can show up in the neonatal blood, and the neonate has to combat these actions, and often that is depressive to the neonate. So the area of placental transfer drugs is relevant not only during fetal development, but just around the time of delivery as well. All right? Now, what about the other barrier, the blood-brain barrier? This is much more formidable. If you want a drug to go into the brain, you've got to have a very small molecular size, or you've got to be lipid soluble. The smallest drug we know is lithium. Lithium is an ion, just a few Daltons, all right? Lithium can cross the blood-brain barrier. It's an ion, it's ionized. This is the real exception to the rule that ionized forms don't cross membranes. Lithium is so tiny that it can cross membranes. There's no problems with that, even though it is an ion. And lithium, of course, is our premier drug for treatment of manic depressive disorder, bipolar affective disorder. Another drug that's relatively small is ethanol. Ethanol's molecular weight is just 44. That's small for a drug molecule, by the way. Ethanol isn't particularly lipid soluble, but is still small enough to get into the central nervous system. Having mentioned those two drugs, lithium and ethanol, now you can categorically say that any other drug that's going to work on the brain is probably going to be quite lipid soluble, because, you know, the brain is made up of a lot of lipid, and that sort of clues you into the idea that you'd have to be lipid soluble to get in there. And in fact, that's really true. And here's something for you. Anything that gets into the brain breezes across the placenta. I mean, there is no drug that gets into the brain that can't get into the fetal circulation. Once again, we're concerned there about embryotoxicity. Lithium is toxic to the developing fetus, right? It can get across the placental barrier and actually causes cardiovascular problems in terms of valvular structure. So lithium should not be used in pregnancy for the obvious reason. So the blood-brain barrier, being much more formidable, says that if it can get there, the drug can get anywhere, right? That's the principle. Now, Redistribution. Redistribution concerns the situation, usually with fat-soluble molecules, where even though there isn't much blood supply to our adipose tissue, with time, especially with chronic administration of a drug, you will actually begin to slowly saturate fat tissue. Now, you stop giving the drug, but the pharmacological effects don't go away as quickly as you'd anticipated. And you can see why if you realize that what you've done is set up a situation where the drug has been sequestered in body fat. Now it's got to come out of that fat before it can be finally eliminated. And as it comes out and it goes into the blood, it continues to exert effects. And this is a phenomenon called redistribution, right? You may prolong the duration of a drug by virtue of sequestration or, if you like, redistribution from sequestered sites, mainly the fat tissues, into the bloodstream. So this is not really a special barrier to distribution. It's really a separate item, but it does fit under distribution. Now, I'm going to ask you now to get a little bit mathematical, not too seriously. And it concerns a set of things that we need to know about pharmacokinetic parameters. One parameter that I need you to know about is called the apparent volume of distribution. It's usually designated as V subscript D, VD, and it's given by dividing the dose of a drug by the concentration that occurs at 0 time in the blood. And this is a parameter that we need to remember. This is one of our keepers. When I say, know something well, I sometimes use the phraseology, keep it. All right? So this is a keeper to know this relationship here. Now, actually, most of the time we don't know what the concentration is at 0 time. So if you want a rough approximation, you can say peak plasma concentration. That gives you something close to the same thing. Half an aspirin is 160 milligrams or thereabouts of aspirin. And that would be the dose I took, 160 milligrams. Now, if I were to be able to measure the plasma level that peaked following that aspirin, I would have found it was 16 milligrams per liter. 16 into 160 gives me the number 10. And the volume of distribution of aspirin is 10 liters. And that's how you would do it. That's how you would measure a volume of distribution. You take the dose, you divide it by the plasma concentration. It really should be C0, but C peak is probably pretty close, and that would give you then the volume of distribution of a drug. Now, in general, volumes of distribution, if they appear in an examination, if they are given as units of liters, they are referring to a patient that's an adult patient of approximate weight 70 kilograms. So if there is not any designation of weight, then we use the term liters. And in my case, I may be a bit more than 70 kilograms, but near enough. So 10 liters is the volume of distribution of aspirin in my body. Right? Now, what if I was only about 10 pounds or 5 kilograms? Well, obviously, I'm not going to have the same volume of distribution. So in the pediatric arena, it's very common to give volumes of distribution in liters per kilogram. And if a patient, for example, weighed 10 kilograms, then you would multiply the volume by the 10 to get the total volume of distribution, for example, for dosage calculations. When I said that this is a keeper relationship, you probably would guess then that this, if you rearrange the equation, could give us dose equals VD times blood level. You see how we could do that fairly easily in a rearrangement? Dose equals VD times the concentration in the blood. And that is actually a way of estimating loading dose. So when you have things that can have more than one value for you, they are worth keeping at the back of your mind. And you'll see this come again when I show you how to do a loading dose. It's the same relationship. Okay, principles of volume of distribution. Well, if you looked at the relationship VD equals dose over blood level, you would say the higher the VD, the lower the blood level. It has to be that way. I mean, simple arithmetic tells you that if the blood level is low, you will get a high VD. If the blood level is high, you'll get a low VD. In fact, aspirin in my body is very extensively bound to plasma proteins. Therefore, the blood level is going to be high. And that's why I have a VD that's relatively low, 10 liters. Now, suppose I'd taken Prozac this morning, fluoxetine, an antidepressant that everybody knows, right? What would I expect to see of a volume of distribution there? Well, you know, it's in several thousands, right? Several thousand liters. What does that say to me? It says the blood level must be very low. Where is that drug? Well, I suppose some of it's in my brain if I'm using it for depression, right? But all I can really say is it's not in the blood. In other words, high VDs go with low blood levels, low VDs go with high blood levels, right? It's simply seen there by that relationship. So if a drug is extensively bound to plasma proteins, warfarin is, we used that as an illustration earlier, aspirin is, you can anticipate relatively low volumes of distribution.